My name is Brian Wood, Medical Director for the Mountain West AETC ECHO. Welcome to this week's session, and I will turn it over to today's speaker.
Great, thanks. Well, it's nice to be back here. Actually, presented here on February 6th of 2014, and that was about 2 years after we started our HRA, High Resolution Anoscopy Clinic here at Harborview. And the title of that talk was Lessons Learned from Starting Up a Clinic. So now we're more than 4 years down the road and want to talk about a lot of the research studies and things. Because initially, when I talked to Brian Wood about this, he was thinking of having a debate format, but there are studies out there now that are going to answer the questions that we don't have consensus on. So that's what we're doing here, and I'm going to talk a lot about that, the studies that are ongoing, particularly the anchor study. And then we should have time for questions and answers, I think, given the cases presented today. So I do this both at Harborview, Virginia Mason is where I'm doing these studies right now. We'll talk more about that. I have no conflicts to disclose. So I'll talk about the anchor study a little later, but these are some slide sets from their website. They have a nice website, anchorstudy.org. A couple of points to emphasize. Anal cancer is much more frequent among HIV-positive men and women than the general population, up to 130 times more prevalent in HIV-positive gay men than in women in general, even though it's still more common in women. But men who have sex with men are about 35 times more likely to develop anal cancer than women in the general population, and HIV-positive MSM are up to 130 times more likely to develop anal cancer than HIV-negative men. Now, the rate of anal cancer in the general population is about 1 in 100,000, so these relative risks are great, but still the absolute numbers are relatively low, hence the debate about screening and treating, and whether we're preventing anal cancer by treating high-grade anal dysplasia. And anal cancer rates, as I'll show you, are rising in HIV-positive men and women despite antiviral therapy, and it's almost always preceded by a precancerous lesion called high-grade squamous epithelial neoplasia, and that's all driven by high-risk types of human papillomavirus or HPV infections. So if we screen HIV-positive men, about half of them have high-grade anal dysplasia, and these are people without any symptoms. So this is a very prevalent precancerous disease. And we think, and this estimate is really an estimate, that about 1 out of 10 will develop anal cancer in their lifetime of people with high-grade anal dysplasia. So if half of the population has the disease, about 10% of them will develop anal cancer. And in women, the numbers are less certain, but probably lower. About 2 out of 10 women with HIV, if we screen who are asymptomatic, we find high-grade anal dysplasia. And we don't know how many of them progress to anal cancer. It's clear that anal dysplasia progresses less often to cancer than cervical dysplasia does. And, you know, there never was a randomized study to treat or not treat cervical dysplasia to prevent anal cancer because it was so clear, it was so effective. It's not that clear with anal dysplasia treatment. So the risk factors here are all driven by the high-risk strains of human papillomavirus, the most prevalent certainly being type 16 and 18, but we're seeing some other types as well. And we'll talk about the Gardasil 9 vaccine, which covers 7 of the high-risk types of HPV. And the other risk factors are older age, having a history of a low nadir CD4 is a predictor, as it is for most AIDS morbidities. Smoking, certainly for persistent high-grade disease, and then history of genital warts and history of cervical or vulva high-grade. So just note here, this is kind of the diagram I like to use when talking to patients. You know, we used to think of this as a continuum from low grade to moderate to high grade. We now divide everything into low grade and high grade, and this is per their most recent pathology recommendations called the last recommendations, or the lower anal genital tract terminology recommendations. Everything is divided into low grade versus high grade. In these kind of intermediate lesions, we do P16 immunohistochemistry to look for presence of the high-risk HPV strains. And that becomes the decider on these ones that are really intermediate here. But we really think of the low-grade ones being what we see in condylomas, associated with low-risk HPV strains, not associated with cancer, and then the high-risk strains being the ones associated with high-grade dysplasia, and then invasive cancer in a subset of people with high-grade dysplasia. So anal dysplasia and anal cancer is a significant problem in the population of people with HIV, and this is specific incidence rates in the NA Accord, which is a big national database. And if you look at anal cancer incidence rates, it's 60 per 100,000 person years in people with HIV versus 1 per 100,000 in people without HIV and matched controls. So at least a 60-fold increase in this study, and like I said, some studies have showed a 130-fold increase. So we're talking about very large relative risks here. And the other important thing to emphasize is that, well, the traditional AIDS-defining cancers have decreased. So these are different calendar years, the most recent being the 2005 to 2009. And you can see that with Kaposi sarcoma and Hodgkin's lymphoma, the highest rates were in the early years of the epidemic. The lower rates are more recent with antiviral therapy. That's not the case with the non-AIDS defining cancers. So the highest rates here are the most recent time period, the solid line here for anal cancer, the same for colorectal cancer, liver cancer, and lung cancer. So we're seeing an increased rate of these non-AIDS defining cancers across the board, but significantly so for anal cancer as well as the others. And I just want to run through a couple of recent studies here, just verifying this data with more recent cohorts. This was a study published last year in AIDS, and the significant thing here was that the percentage of HIV positive men, again, these are asymptomatic people who are screened with high-resolution anoscopy, 17% with AIN2 and 12%, so almost about 30% have high-grade dysplasia in the screening population. And the conclusion here in terms of relative risk factors are that young HIV positive MSM without viral suppression were at the greatest risk, but given the high prevalence of high grade, again, even among virally suppressed men, the conclusion here was that all HIV positive men should be screened for anal dysplasia. And we'll come back to that in the context of the ANCHOR study, because that's one of the key goals of the ANCHOR study, is to address the screening question as well as the treatment question. So this was the NHANES data, national survey data, using self-collected penile and cervical vaginal swabs in people aged 14 to 59. And self-swabbing has been proven and validated as a reliable technique to detect HPV DNA. Probably not as reliable for cytology, but for genetic testing, it's very reliable. And the significant thing here is how prevalent genital HPV is. And these are different age groups. This is HIV, HPV, any HPV, and then the dotted lines are the high-risk HPV. And in A is the general total population, and then it's broken out by ethnicity in the other three panels here. But if you look at the age of acquisition, it's really fairly early on in the 20s and 30s. Most people pick up multiple strains of HPV soon after sexual debut, very prevalent, and even the high-risk types are very prevalent. You have 30% in age 25 to 30 have high-risk HPV, and even higher in women. And if these in different ethnicities, this is in African Americans here, people of color, you see rates of over 50% of prevalence of genital high-risk HPV. So the precursor lesion here is very, very prevalent. This was another cohort study looking at the prevalence in MSM and MSW, looking at men who have sex with men as compared to men who have sex with women. And much more prevalent in MSM, but still very prevalent in MSW as well. So type 16 and 18, the prevalence rates of 13 to 24% or 38%. And also the conclusion of this follow-up study was that MSM had a higher prevalence and incidence of human papillomavirus, but similar clearance rates. And receptive anal sex is another probably risk factor for both acquisition and persistence of high-risk HPV types. The other important thing I want to note before we go into more detail about the ANCHOR study is that antiretroviral therapy doesn't mitigate this risk like it does for risks like Kaposi sarcoma, Hodgkin's lymphoma, pneumocystis pneumonia. We don't see those very prevalent in people with higher T cell counts. That's not the case for anal dysplasia. So this is prevalence of high-risk anal HPV and MSM versus men who have sex with women, MSW, by CD4 level. And you see very little trending down here with the higher CD4 counts. So still very prevalent even in people with suppressed viral loads and high T cell counts. And then, treatment is debatable because there's a high recurrence rate. And one thing we're going to be doing in the ANCHOR study, hopefully, is identifying which are the lesions that we need to treat and which ones are more likely to recur after treatment. So I found an interesting paper published in JID recently looking at some the immune microenvironment. And it may be that we are going to be able to identify some biomarkers to identify which of these prevalent lesions we need to treat and which ones we don't. And we just don't know what the answer to that. And these are the kind of studies I think that we'll be pursuing in the ANCHOR study as we go along. There were a couple of modeling papers published last year, one in cancer, one in vaccine. They essentially were the same paper published in 2 journals by the same authors, which is, I guess, nice if you can do that. I question the utility of that. But this was using a decision and analysis model and using current data. But what they did here was projected and assumed some efficacy of the HPV vaccine, which I'll talk about later, to prevent recurrent high-grade disease, and also that treatment would lower the risk of cancer. Well, if you make those 2 assumptions, you can show in a model that treatment and vaccination is cost effective. But the data they're assuming this on is active research. But what they concluded here was that this is, again, assuming that the HPV vaccine has some efficacy in reducing recurrences and assuming that treatment reduces the risk of anal cancer. And those are 2 big unanswered questions right now. But if you assume that from some observational data, then you can see that doing nothing, there's an projected incidence of anal cancer, that the rates drop down significantly when you combine treatment with vaccination over the course of a lifetime. That active monitoring it allows you for early diagnosis, and I'll show you that that's of great value, but it doesn't lower the incidence of the anal cancer. So again, this is all based on some assumptions. So this is the design of the anchor study, which is going to address how valid these assumptions are. And then I'll talk about an HPV therapeutic vaccine study that we're doing locally here to address the impact of vaccination. Since most people acquire multiple strains of HPV soon after sexual debut, virtually everyone that we see and screen who has HIV is already infected with multiple strains of HPV, so there's no real preventative effect of the vaccine. So the projection for the anchor study is that we'll enroll 5,000 people, and these are HIV positive people, men and women over age 35 or older, who are screened and found to have high-grade anal dysplasia. So about half of the people that we screen, we find high-grade anal dysplasia, and if those people are willing to be randomized to one of 2 very different strategies, one being what we call an active monitoring arm, which basically is a no treatment arm. So we follow people every 6 months, rebiopsy the lesions every year. And the other group is an intervention arm then, where we treat and try and aggressively treat any high-grade dysplasia, and if it recurs, retreat it. So it's really a treatment strategy trial, and we'll talk about the different options. So treatment here, primarily this is with ablation or hyfurcation of the lesions. Sometimes we use topical compounds that I'll talk about, but primarily this is by hyfurcation ablation, which we can do readily in the clinic without any conscious sedation needed or anything. I'll show you a couple of pictures of that. So the end point here is cancer, though. You know, high-grade dysplasia in and of itself is almost always asymptomatic. There's no real reason to treat it unless your goal is to prevent cancer. So in this study, though, of 5,000 volunteers followed for 5 to 7 years, we're going to follow people 5 years after the last person enrolls. We estimate less than 50 will develop cancer. So even though this is a fairly prevalent pre-malignant condition, the incidence of malignancy is fairly low. So we need a 5,000 person study followed for 5 to 7 years. So we've now screened our 5,000th person this week. We've enrolled about 2,000 people in the study. We're just under 2,000 right now in the study nationally, and I'll show you where the study's going on. So over the 5 years, we see people every 6 months. If they're in the treatment arm, we keep aggressively treating high-grade dysplasia to try and get rid of it. If they're in a monitoring arm, we biopsy once a year to see if there's any progression or invasive cancer, or biopsy at any time that we think there's invasion. And people get a $100 compensation. All these visits are billed to insurance. So the primary objective here is to determine whether treating high-grade dysplasia is effective in reducing anal cancer. So that's the endpoint, is invasive anal cancer. There are some secondary endpoints, and I think a critical part of this study may teach us about which of these lesions we need to treat and which ones we don't, because most of them don't progress on to cancer. So the study assumes an anal cancer rate of 100 per 100,000 among HIV-infected men and women, and if half the population of the population that develops ASIL, the incidence of cancer would be 200 per 100,000, and in that half that we're not treating. So that's how the study is powered. These are the sites that are doing the study around the country. We're kind of in the second tier in that the initial sites were San Francisco, Chicago, and New York, and then these other sites came on board. So this is a real large national effort, funded to the tune of about $80 million by the National Cancer Institute. And here in Seattle, we're enrolling at Virginia Mason at Harborview, and Wanda Laosa, general surgeon of Poly Clinic, is enrolling there as well. David Abalafi of Virginia Mason is the PI on the study. So a couple of other studies that are going on to address some of the other issues here. This study will address the screening question and the treatment question. For topical therapy, for people with multifocal or diffuse high-grade dysplasia, we sometimes will use topical compounds. The two most commonly used ones are, and this is with intraanal use, which these are not necessarily licensed for intraanal use, but that's how we use them. So either topical 5-FU, fluorouracil, or imicramide, Aldera. And so there is a study going on in the AIDS Malignancy Consortium comparing these two directly head-to-head. The feeling is that imicramide may work better in people with higher T-cell counts, and Efudex may work better in people with lower T-cell counts, because imicramide depends on an immune response, but that remains to be seen. No one's ever done a head-to-head comparison. So this study is ongoing and enrolling. And then the other study that we're doing locally here is called the VIVA study, or the vaccine study. And this is a therapeutic vaccine study led by Margaret Madeline at the Hutch and Anna Wald here at University of Washington. And this is a local study. We're enrolling people who have a history of anal or vulva high-grade dysplasia. And the reason we picked those two is that those are the ones with a high rate of recurrence. There's a fairly low rate of recurrence after treating cervical dysplasia. So people are randomly assigned then to the Gardasil 9 vaccine, which is the most current vaccine on the market, which includes 7 oncogenic strains, and type 6 and 11, the two most common associated with warts, or placebo. One thing about the design of this study is that people have to be free of high-grade dysplasia at baseline. So these are people with a history of high-grade dysplasia who currently don't have high-grade dysplasia. The primary endpoint of the study is time to new high-grade lesions then. And follow-up exams are done at 18 and 36 months. So as of last month, we've screened about, or I should say contacted about 700 people, because high-grade dysplasia is reportable to tumor registries, even though it's not an invasive cancer. We're using that registry to contact people. We've conducted over 120 screening interviews of people who expressed an interest after receiving a letter informing them about the study. And we've enrolled about 50 participants now. We do find a significant number with high grade at baseline, so they're not eligible for the study. They can go have their high grade treated and come back 3 to 6 months later, and if they're free of high grade, then they can enter at that point. But particularly with anal, recurrence is a real problem. So 16 of the people that we screened have active high grade dysplasia at screening and are deferred entry at that point. There are, though, negative studies here. There's a retrospective cohort study that showed some benefit of therapeutic vaccination, but this study was a study done by the AIDS Clinical Trials Group, just published a couple of weeks ago online in Clinical Infectious Disease. It was done by Tim Wilkin and colleagues. And this was a randomized trial comparing the quadrivalent HIV vaccine to look at both risk of acquisition of HPV and also its effect on decreasing recurrences in people who had previously had biopsy-proven high-grade anal dysplasia. So the primary endpoint here was vaccine efficacy against incident and persistent infection and recurrence of high-grade dysplasia. This study this just again reinforces the prevalence of these high-risk HPV types. So in this cohort, they had a high rate of detection of the high-risk types of HPV, over 50%. And the Data Safety Monitoring Board stopped this study early for futility because there was no difference in protection against acquisition of new types or in recurrence of high-grade. It did seem to have some effect on clearing and preventing oral HPV infection, so the study team felt that finding should be pursued. But this study did not support therapeutic HPV vaccination of adults over age 26 for new infections or to improve HSIL treatment outcomes. So I would just make one other point. Then I'm going to just show you a few slides of what the images look like and things, so you know if you send patients and you're getting pictures back, you get a sense of what we look at, what we're doing when we're doing this exam. If you're going to set up a screening program, the first step usually is an anal pap smear or cytology. The problem in screening is you really have to have everything downstream set up like I talked about when I spoke about this 4 years ago, because anyone with other than a normal cytology, and most MSM and most people with HIV don't have normal cytologies, they have at least atypical cells of clinical uncertain significance or low grade or high grade. And all of those folks who don't have a normal pap smear really need to go on to get high resolution anoscopy. So unless you're really set up and have a referral system and an endoscopist and a surgical chain where you can refer people on for treatment and diagnosis if they need surgery, then I wouldn't screen, because you really need this whole cascade in place. And the vast majority of people, if you're screening high-risk people, will need to have high-resolution anoscopy. When we're doing these exams, this is what we're looking at. We're looking with a microscope or a modified colposcope. This is the rectal mucosa, and as we bring the scope out, this is about 2 centimeters into the anal canal. The diameter of this anal scope is 1.5 centimeters. So this is about 16 power magnification. This is what the normal healthy transition zone epithelium looks like. This is with a little bit of acetyl white vinegar on it. And it's thin, pale, translucent, and I'll show you what abnormals look like. Occasionally you'll see a little island of squamous metaplasia, a little more proximal. That's nothing to worry about. But this is basically what we're looking at when we're doing this exam. Then we use Lugol's iodine. Lugol's iodine stains normal cells brown. Abnormal cells don't pick up the Lugol's iodine. The problem is this isn't very specific for high-grade dysplasia. So hyperkeratosis, low-grade dysplasia, and other things will inhibit the Lugol's uptake, but it does help to identify extent of lesions and identify lesions. These are the kind of lesions that we're looking at. These are very subtle. The most obvious things that you see if you're doing an office-based anoscopy is usually not high-grade dysplasia. It's usually condyloma or squamous metaplasia. The high-grade dysplasia lesions are the most subtle. We look for coarse punctation and vessel patterns or mosaic vessel patterns. Vasculature is a hallmark of these abnormal lesions. And you can see the thickening with the vinegar here. This is the normal transition zone here, and then this is the thickened area with vinegar, a little friable vessels, and coarse punctation and mosaicism. So this is a very obvious high-grade lesion to someone who's experienced in doing anoscopy. So the reason we're doing this is to prevent this. This is a person who presented here last year with a painful rectal mass, had never had high-grade high-resolution anoscopy done. Certainly it doesn't always prevent cancer, but this person presented with a very symptomatic cancer, underwent radiotherapy, combined modality therapy with chemotherapy and radiation therapy. 6 months later, he was referred to me for a follow-up anoscopy. This is the first time I saw him last month, and this is a large recurrent rectal cancer that on biopsy showed anal cancer recurrent. So this is what we're trying to avoid. Even if we're not preventing cancers by doing high-resolution anoscopy, we have a high cure rate and hopefully won't see many of these failures of therapy. So this person has involvement of the prostatic urethra, prostate, and base of the bladder right now, and is being assessed and is in a very dire situation. So this is hopefully what we'll see is a more localized lesion. This is a person that I saw over at Virginia Mason, asymptomatic, came in for a screening, high-resolution anoscopy, and had an anterior proximal rectal lesion that turned out to be squamous cell carcinoma. So this was a fairly proximal lesion. Sometimes they'll do that. They'll run up into the anal canal further than the transition zone and dentate line. And this person underwent radiotherapy and chemotherapy 2 years ago and has been free of disease since. And then this is the more subtle, and this is a patient who's on the anchor study that I followed. He was in the active monitoring arm. He came back a year later, and this had been biopsied at baseline, no invasion. 6 months was no different. At 12 months looked no different, but on biopsy this was an invasive anal cancer here, and we took him to the operating room 2 weeks ago and excised this, and he's going on to chemo and radiotherapy now and should have a very high cure rate. And this kind of a lesion would never present with any symptoms. So even if we're not preventing cancer, we're certainly diagnosing the rare cancers that we see very early. And we'll have a much better treatment outcome than the prior patient I showed you. These are the kind of descriptions you'll see in my notes. We talk about the color of the lesion, the margins, the contour, the vessels, coarse punctation, mosaicism, Lugol's positivity or not. So that's the kind of descriptive terms we use. And just a few last comments is that there is a very long learning curve in doing these procedures. You certainly don't observe one, do one, and teach one. It's much more like do 50 and you feel like you're still not sure what you're doing. Lesions can be very subtle, and the obvious lesions are usually not. And one of the problems in being experienced in this is finding all the lesions, because oftentimes these are multifocal. And so extent of lesions, particularly for a study like the anchor study, is very important. These are the two main ablation techniques. A lot of people used to use the infrared coagulator, which is very simple to use. The hyfricator is what most people use now. Ablates the lesions. The efficacy and toxicity, tolerability is about the same, but the hyfricator is much quicker, and you can do a much more pinpoint type ablation of the lesion. You just need to inject maybe a cc of lidocaine because of the heat that patients experience with this, but this is very readily done in an office-based setting without much morbidity to the patients. And this is an example of a hyfrication of a large condyloma. The hyfricator works very well. It takes about 5 minutes to ablate this lesion with a hyfricator. and do this with about a cc of lidocaine. It's actually works very, very well. And likewise for the high-grade dysplasias. So, challenges in setting up, again, this is a slide I showed last time, 4 years ago, is training, equipment, space. No-show rates remain high. Even though the tolerability of this procedure is pretty well for most people really don't enjoy coming in for these visits. They'd rather not if they didn't have to. And, we don't have the level A evidence to show that treatment is beneficial, and that's what the anchor study is all about. It's the one attempt and large attempt to try to show that treatment is beneficial. But even if it's not, we're finding cancers much, much earlier than we would if people came in with symptomatic disease. And so reimbursement is less of an issue now than it was 4 years ago. I think that most insurance companies are now paying for this. There are now permanent billing codes. We don't have temporary codes. So that's been less of an issue than it was initially. So I'll stop there and be happy to answer any questions.